Hello, Gavin. It's a real pleasure to have you here with us, and we truly appreciate that you traveling so far to be with us to share your experience with our society. I think there is no better way to start this conversation than by talking about the topic that has been really at the center of discussion in the last few months, and is the bounce of the from the data study. After the presentation of the lot of data, and especially following the excellent CTS interview with Jordan, where you present some very fruitful arguments about segmentectomy, and you raise important questions about how to interpret the data and also potential biases of the trial, and why segmentectomy may still represent not only a valid option, but actually selected patient that has even the most rational resection. Yeah. So I would like to explore some of those ideas with you today. And I
Absolutely. Well, thank you very much for inviting me for a start. I've had a great time in Cádiz, and been terrific to talk to your society in the conference. With respect to the segmentectomy data, the way the results were reported was actually the issue, not the differences in the results. So we, both the CELGB study, which I was a part of, and the JCOG study, reported the median differences in FEV1 and FVC between the two whole groups.
Yes.
Now, the whole statistical purpose of a median is to remove the outliers.
Yeah.
So you may be looking at, say, the middle 50%.
Mm-hmm.
And we're not particularly concerned what happens to the middle 50% because the differences are small. But it is exactly the outer 25% that we're worried about.
Yeah.
What happens in the extremes? Are there lobectomy patients that are suffering greatly because of having that lobectomy choice over anything? And so I looked at the published JCOG data, which I could identify the median, identify the interquartile range, I could identify the 95% confidence interval, and I could do an approximate distribution of the two groups in the JCOG study, just from what's already published.
Yes.
And it immediately became obvious to me that there is a large group of lobectomy patients with quite catastrophic decline of FEV1. So that led to me making those comments after Asamura had claimed there is no reward for doing a segmentectomy. I thought, well, that's might be true by media, but not true in actual.
Exactly. And regarding that, also it has been talking about the number of segments that has been taken in consideration that were just two for the data of the study. And you did a really good analysis about the numbers of segments and how these bias could be.
Yeah, exactly. Well, they pre-specified, and this is not in any way statistical. The JCOB study pre-specified that they would only consider the lung function improvement if it was better than 10% difference. Now, when you line up all the different types of segments and loads done in the study, it's almost impossible to exceed for 10%. That would be totally the best case scenario to have 10% difference if the amount of lung you took out is exactly changed by FEV1, which is not true anyway. So the actual pre-specified rule was very flawed, and they should have just looked at the distribution and decided did more harm come to lobectomy patients in terms of FEV1 compared to segments. That is a different question to is the median difference any worse?
Exactly. There is also some criticism about the an error one, and a statistical error one, which also you mentioned that may relate it to the numbers of patients, and this is something that sure, yeah.
Yeah, so type 1 errors do occur in large studies. The larger the study you have, the more patients, any random thing that happens enough, you will get a p-value of less than 0.05. That's why we don't go fishing for things. They're not the primary endpoint. However, in JFOG, firstly, overall survival was the primary endpoint.
Yeah.
Secondly, it was absolutely properly empowered to discover that difference.
Yeah.
Thirdly, the difference was even greater than what they patterned the difference for.
Yeah.
So I would say that's not a type 1 error. That is the conclusion of the trial.
Mm-hmm.
So I reject the idea that there's a type 1 error. And the other misconception is people think that there were more cancers in the lobectomy group, that actually there were the same number of cancers.
Yeah.
But people with their new cancers tend to die in the lobectomy group as opposed to secondary. So that may go to the underlying physiology after the lobectomy. It may go to whether their treatment intensity is enough. There may be many plausible reasons for that difference.
Yeah. And also, something that is also really important is the recurrence rate. We know that with segmentectomy you have high recurrence rate, but then it's not reflected in an overall survival. How can you explain that, or what do you think? And in a practical manner, what do you do when you know that maybe a patient with a segmentectomy, a select patient, would have maybe a lot of recurrence, but
Yeah, I think the local recurrence difference is real. And if you look at combining the German-speaking trial, small trial, the CALGB trial, the JCOB trial, if you pull all the local recurrence, there is a 4% excess in local recurrence.
Yeah.
If you do a subloader. For me, that's not terribly surprising. And it probably is partly related to individual pathologies, make you more prone to locally recurring if you don't take the whole load. But if you get a recurrence in a segment and it's still local, it's likely you can do a completion lobectomy. So basically, for those 4% patients, you may have to put them through a 2-stage procedure, but it didn't seem to affect their long-term survival. So the distant recurrence rates are about the same. So biology is king, as we know. So if you have a nasty tumour, it can kill you regardless of your resection.
Yeah.
But if you have a locally recurring tumour, you may be able to salvage that. And if it's not with surgery, it might be with radiation. So I think that, to me, explains why there's no difference in lung cancer mortality. In fact, none of the studies have shown a difference in disease-free survival or lung cancer mortality.
exactly. Also, something that I quite interesting is the probability to have a second primary, which is also something that we will see. We're looking after now that with national lung cancer screening, and we see patients with a high risk. So to have one cancer is higher risk than the second one. So which is also a kind of data that we really need to consider to make decisions about superior resection. And so, what do you think in your daily practice? Have you changed your practice a bit, or you're taking consideration on, because there's so many variables? I think we really need to personalize and make decisions in every case. That's why MVPs are so important, to get all the data to really. So, have you changed your practice, and how do you really select patients?
I would say that I've become, since the knowledge of these trials, and obviously I had some advance notice of the CLGB trials, as I was part of that trial. I've certainly accelerated the move to segmentectomy. There's no question. And I quite possibly do. I certainly do more robotic segmentectomies than robotic lobectomies now. Partly because I prefer to do them by his robotics. But that has changed. And the local recurrence thing has changed my approach to, for example, I will be more likely to take 2 segments than try and get it into one segment, even if the tumour is one segment, because I have to tell myself it's not the tumour I'm removing, it's the tumour plus margin. And that may well cross an intersegmental plane. And in fact, in the COGB trial, we had to try and get at least a centimetre margin. The surgeon had to attempt that. And probably we weren't as aggressive as we have been now. So I am hoping that the real world results, when people know about local occurrence, may actually in fact reduce that local occurrence. And the other thing is the JCOG trial, they only allowed them to take 2 seconds.
Yeah.
So I wonder if there was just a little bit of pressure for some surgeons to take the 2 segments, when maybe they should have taken 3 or done a common basal segmentectomy, which was not allowed in that trial.
Okay. Yeah, that's right. Well, let's take this subject, which is coming from Australia, July 25, you finally implement the local search training. And here in Spain, we're really strong. Now we have a pilot project, which is working really well, and it's multi-center pilot study to try to demonstrate what has been demonstrated. So, first question is, what do you think as a society or can we do? What we can do for to get that implementation, and what is the change in practice since in Australia started the national lung cancer screening program?
Yeah, look, the lung cancer screening program in Australia was actually many years in the making. I was one of the members of the expert advisory committee. I was the chair of the lung cancer advisory group for Cancer Australia, and Cancer Australia was tasked with, first of all, scoping out a lung cancer screening program and then with implementing. And it's a very large job, and the more you get into it, the more layers there are. If you want to do a really proper program, I think the programs that exist in the US, for example, which is state-based or just a provider item number that can be built, that is not a program, and hence it's been very poorly implemented. Our program included looking for how it was going to be advertised, and looked at the issues that might be barriers, stigma, vulnerable groups, people who don't have GPs, how we're going to reach those people. Also, we don't want to cause harms with a lung cancer screening program, so we actually created a very protocolized system to deal with nodules that were found in these screens, because we know there are a very high chance of incidental nodules.
Absolutely.
And we don't want to end up operating on anyone, and then even worse, causing some mortality. So I think those sides of things were very well done with the lung cancer screening program. And we had we had 2 fears actually. We had one fear was, are we going to be overwhelmed? Suddenly have all these cancers. And our other fear was, is it really going to work? Is it going to start bringing, so each extreme we were worried about. But in the end, it's actually worked out okay, because obviously there's a ramping period where it's just getting a bit communicated out to the community, and they had a bit of a soft launch, so it didn't suddenly get blasted. Because the problem for Australia is that the screening program is run by the federal government, but it's up to the state governments to deliver the surgery and the investigations, etc. So I think the federal government didn't want to swamp it in the state government. But it's actually come on quite slowly, although now it's reaching every multidisciplinary meeting now is a couple of patients that come off the screening program. That's now become a common entry point, which is fantastic. I mean, some of those are patients that have now got very easily cured cancers. And some of them are patients we might have diagnosed in 6 months, but now we're diagnosing now with smaller or less advanced tumors. So the surgery is more favourable for those patients.
Okay, good. And last question is like, how do you see the future of thoracic surgery 5 to 10 years?
Well, I think there'll be continued advances in the robotic, minimally invasive field. I think ultimately, it may not be today's machines, but I think we'll all be doing a single port, probably perhaps intercostal, perhaps subcostal, I'm not sure which. But I think the important thing about robotics is that it democratizes certainly minimally invasive surgery that all surgeons can do. And of course, we need to have access to robotic surgery for all populations, not just the ones that have the most money.
Yes. Yeah. Well, thank you very much, Gavin. And yes, a real honor and a pleasure to have you here in Cádiz. And well, thank you for your time.
No worries.
Thanks.